The other interesting finding, for which there are now several trials as well looking into this question, is the value of using this non-invasive method to identify acquired mechanisms of resistance. For colorectal cancers in particular, we know that when anti-EGFR therapies like cetuximab or panitumumab fail, there are acquired RAS mutations that are present. Historically, these were identified in many trials, and there is a meta-analysis that also has shown that you can identify these mutations both in tissue as well as liquid, depending on the methodology used. But at present, this was not necessarily practiced to be rebiopsying these patients because you were not going to do anything different. However, interesting data by using serial analysis has shown that these clones decay over time. So arbitrarily, you could potentially, quote-unquote, recycle or re-challenge the patients with the same treatment that potentially stopped working if the acquired aberration faded away. Because it's non-invasive, it's just a blood test, you can now do these repeated assays that you didn't have the opportunity to do that before. And we'll show some examples where we've done re-challenge, and not just our experience, but there have been many publications within this year that have looked into ctDNA presence of RAS, EGFR, and other mutations that confer resistance to anti-EGFR therapies. If they're present, the likelihood of the treatment re-challenge working is low, if not minimal. And if they're absent, there are patients who respond who could potentially benefit from this approach.